So now we are going to discuss about labor. So labor we have stages. So first stage is onset of labor to full cervical dilatation. That is the first cell stage of labor. So what is the full cervical dilatation? It is up to 10 centimeter. The cervix can dilate maximally up to 10 centimeter. So the onset of labor to full cervical dilatation, that is 10 centimeter, is called first stage of labor. And what is the second stage of labor? After the cervix is fully dilated, then the full dilatation of cervix to expulsion of fetus, that is the second stage of labor. So first stage of labor is onset of labor to full dilatation of cervix, that is 10 centimeter. Second stage of labor is full dilatation of cervix to fetal expulsion. And during the second stage we see the spontaneous rupture of membrane, because before the delivery of fetus there will be membrane rupture, and that is called spontaneous rupture of membrane, that is seen in second stage of labor. And what is the third stage? Third stage is the stage of placental expulsion. And the fourth stage is observation of the postpartum female for 2 hours. It's called fourth stage of labor. Now the phases of labor. So phase 0. Phase 0 is called inhibition of uterine contraction due to progesterone. So phase 0 is inhibition of uterine contraction due to progesterone, that is the phase 0 of labor. So that is inhibition of uterine contraction due to progesterone. And the first phase of labor, the phase 1 of labor, is myometrial activation. So what is myometrial activation? That is the preparing of myometrium before the labor. So phase 0 is inhibition of uterine contraction due to progesterone. Phase 1 is the myometrial activation or preparing the myometrium for labor, that is the phase 1. What happens when the myometrium activation takes place? There will be increase in oxytocin receptors, increase in estrogen and estrogen receptors, decrease in progesterone receptors, increase in prostaglandin, increase in myometrial gap junction. So all these are myometrial activation. Again I am saying myometrial activation is the preparing of myometrium before the labor. What we will see in this phase? Increase in oxytocin receptors, increase in estrogen receptors, decrease in progesterone receptors, increase in prostaglandins, and increase in myometrial gap junctions. So all these will facilitate the labor. So during the phase 1 of labor, all these changes takes place in the myometrium. Now the phase 2 of labor. Now in this phase 2 of labor, all the stages of labor comes. So we can say all these 4 stages are subset of the phase 2 of labor. Okay, so phase 2 of labor, it includes all the stages of labor. Again I am saying what is the first stage? First stage is onset of labor to full cervical dilatation. Second stage, it is 10 centimeter. Second stage is full cervical dilatation to expulsion of fetus. Third stage is expulsion of placenta. Fourth stage is absorption of postpartum female for next 2 hours. So these all stages comes under second phase of labor. And what is the third phase? That is the postpartum or preperium period to normal state, when from the postpartum period or preperium period the pregnant female comes to normal state, that is called phase 3 of labor. So we have how many phases? 4 phases: phase 0, 1, 2, 3, and 4 stages. We have 4 phases of labor and 4 stages of labor. All the stages of labor are included in the phase 2 of labor. So now we are going to discuss some basic things, that is the presentation, lie, all these things, the fetal point of view. So lie is the relationship between the axis of fetus and the axis of uterus. So if that is longitudinal lie, then the fetus lies inside the uterus, they are on the same axis, that is called longitudinal lie. Transverse lie, when the uterus is like this, fetus lies like this, that is the transverse lie. The axis of the fetus and uterus are perpendicular, that is transverse lie. Oblique lie is when the uterus is this, fetus like this, that is oblique lie. So we have three type of lie. One is longitudinal lie, one is transverse lie, one is oblique lie. And in longitudinal lie, the fetal height, the fundal height is equal to period of gestation. So in longitudinal lie, the fundal height corresponds to period of gestation. In transverse lie, fundal height is obviously less than period of gestation. You can imagine that. So this is the normal lie, that is the longitudinal lie. So here the fundal height will correspond to the period of gestation. But in case of transverse lie, here the fetus is lying, so this part of mother's womb will protruded. We measure fundal height like this. So this will obviously not correspond to the period of gestation. So frontal height is obviously less than period of gestation. And in oblique lie, it also changes, varies. It is not like equal to period of gestation, it varies. And so what is unstable lie? This is the important thing. What is unstable lie? When the baby keeps changing his position after 37 weeks. When the baby keeps changing his position after 37 weeks of gestation, that is called unstable lie. So here we will see unstable lie, polyhydramnios, placenta previa. In case of polyhydramnios, there is more fluid, so the baby moves more. So therefore it keeps changing position even after 37 weeks. In placenta previa, now the what is the fate of the baby? When if the baby is not present in cephalic position, it rotates and comes to cephalic position. If there is placenta previa, placenta is present in abdominal location, now the baby can come to its normal position, so it changes. So its position keeps changing after 37 weeks. So unstable lie we see in two conditions. One is polyhydramnios, another is placenta previa. So after lie we will discuss about presentation. So in longitudinal lie we can have two type of presentation, that is cephalic presentation and breech presentation. Cephalic presentation when head is down, breech presentation when feet is down. Cephalic presentation is the normal and breech, shoulder, these are abnormal. Shoulder presentation we see in case of transverse lie. In longitudinal lie we can see two presentations, one is cephalic, one is breech. But in case of transverse lie we see the shoulder presentation. So here it is written. And presentation means which part of the fetus is in the lower uterine pole. So which parts of fetus is in the lower uterine pole. In cephalic presentation, the head of the fetus is in lower uterine pole. In breech presentation, the feet of the fetus in the lower uterine pole. And cephalic presentation is the normal presentation. So what is the abnormal? Shoulder is abnormal, breech is abnormal. So among the abnormal, most common abnormal position is breech position. That is the most common abnormal position. Again, breech, we have different type of breech. One is called complete breech or flexed breech, when the hip joint and the knee joint of the baby are both are flexed. When we will do the pervaginal examination, we will palpate both the feet of the baby and the anus of the buttocks of the baby. That is called flexed breech. Another is called frank breech. In frank breech, the hip is flexed but the knee are extended. So during PV examination, we will palpate the buttock but can't palpate the feet. That is called frank breech. Okay, another is footling breech. The foot is down, you can only palpate the foot, can't palpate the buttock. That is called footling breech. So there are different types of breech also. In shoulder presentation, we see the transverse lie. So another thing we have like the transverse lie or shoulder presentation, that is the compound presentation. Compound presentation means the both the head and the hand of the baby are presenting, both head and hand. So this is not an indication for cesarean section. Here we have written compound presentation, both head and hand of the baby present near the lower pole. So what we have to do, reduce the hand, and now it is cephalic, deliver the head. So compound presentation is not an indication for C-section, remember it. So now we are going to discuss about the presenting part. So what are the presenting part? Presenting part are the part what we will going to palpate when we are doing the PV examination of the patient. So the one presenting part is vertex, another is brow, another is face. So look at this diagram. So this is a fetal skull. So this part is called vertex. Okay, so this is the anterior fontanelle, this is the posterior fontanelle. So between anterior fontanelle and posterior fontanelle, this part, this is called vertex. Then what is brow? Brow is present between anterior fontanelle and the orbit. This is called brow. What is face? Face is from orbit to mentos or mental prominence. This is the face. So we have three type of presenting part. One is vertex, one is brow, another is face. So in which condition we will see vertex presentation, in condition with brow and face presentation. Normally we see face and brow presentation, they are the abnormal ones, abnormal presentations, presenting part. We see that in case of abnormal pelvis. In abnormal pelvis, we see the face and brow presentation. I will discuss about that later. Vertex is a normal presentation. Okay. So presenting part we have vertex. What When we will see vertex, vertex is seen in well flexed head. When the head is well flexed, then we see the vertex presentation. When we will see the brow presentation, we will see in partial extended head. Partial extended head, we will see in the brow presentation. Where we will see the face presentation? Face presentation we will see in the fully extended head. So fully extended head we will see the face presentation, partial extended is the brow presentation, and flexed or normal full flexed head we will see the vertex presentation. So another thing is denominator. Denominator is the bony part, bony point on the presenting part. So what is the bony point when we are doing the for evaluation examination? What is the bony part will feel during the examination? So for vertex presentation, the bony part is occiput. Okay, for vertex presentation, the bony part is or the denominator is occiput. So the vertex presentation is normal presentation, so normal denominator is occiput, that is normal. Okay, now for brow presentation, brow is abnormal presenting part, so for brow presentation the denominator is the frontal bone. So this is the bony part we are going to palpate. So for brow presentation the denominator is frontal bone, for vertex presentation the denominator is the occipital bone, occiput. And for face presentation, that is fully extended head, will palpate the chin or mental, this part. This is the denominator. So according to denominator, the position of the baby is named. So occipito posterior. Occipito posterior means, so suppose this is a pelvis. This is a pelvis. This is the sacrum. This is the pubic symphysis. Now if the baby is like this, and this is you can see this is the posterior fontanelle and this is the anterior fontanelle. So with respect to posterior fontanelle, we will calculate the position. So this is what? This is right side, this is left side. Mother's right is our left is mother's right. So this is the occiput posterior. This is the posterior because it's present near the sacrum bone and right side. So right occipito posterior. So this is the position. So it is named according to denominator. Suppose if there was mental bone or the chin present here, in case of face presentation, suppose this is the face presentation and the chin is present here, this is the pelvis, this is the sacrum, this is the pubic symphysis, this is the right side, this is the left side, this is the mental bone. So what will be the position here? It will be right mento posterior. So this mento comes here the occiput O comes here. So the denominators are used for the naming of various position. Okay, and what is the attitude? Attitude is the flexion or extension. Flexion of the head, bony prominence on the opposite side of back. Extension of the head, same side to spine. Suppose the head is extended, now we will palpate the same side will palpate the spine. Suppose the head is flexed, now the opposite side will palpate the spinal back. So now we are going to discuss about position. I have told you the basic already. So these are the positions. The positions are right occipito posterior, left occipito posterior, occipito posterior, occipito anterior, left occipito anterior, left occipito transverse, right occipito transverse. So for normal condition, vertex presentation, this is the most common position. That is the left occipito transverse. So this is we can divide into 1/8. This is 8 part we have divided, so each part is 1/8. So for left occipito transverse position, this is the normal position time at the time of delivery, that is occipito anterior. For this to come to this position, so it have to rotate 2/8 to come to this position before the delivery of the baby. So this is the significance of position. Now we discuss about attitude also. Engagement. So what is engagement? Engagement is largest transverse diameter. It is the bipalateral diameter when it crosses the pelvic brim. That is called engagement. When the largest transverse diameter crosses the pelvic brim, that is called engagement. I am drawing here a diagram. You can see like this. So this is the pelvis, suppose this is the sacrum, this is the pubic symphysis, These are the hip bone. When the largest pelvic diameter, that is the biparietal diameter, from this side parietal bone to this side parietal bone, that is 9.5 centimeter, crosses the pelvic inlet, that is called engagement. On power abdominal examination, that is called 2 by 5. 2 by 5 means when we are doing the power abdominal examination, 2 fingers are like this, 3 are like this. So this is called 2 by 5. Where while you will doing power abdominal examination, you will know that. Now, largest transverse diameter we have discussed, that is the biparietal diameter, then 9.5 centimeter. Now remember the important thing here. I have said it again, now I am saying it. These are the diameters. Okay, so these are the diameters. We have discussed about the transverse diameter. Now we have some anterior posterior diameter. The transverse diameter, this diameter, it can't change, it like this only. Okay, but this anterior and posterior diameter, this can change. Okay, this anterior posterior diameter can change according to the position of the head of the baby. When the head is flexed, there will be one anterior posterior diameter. When the head is extended, there will be another anterior posterior diameter. So this anterior posterior diameter is variable, but the transverse diameter remains same always, that is the 9.5 centimeter. But this AP diameter varies according to head position. So now we are going to discuss about that. So let me clear the diameters for you. So first, remember, this is the skull. First to have remember to diameter like this. This is diameter. This is from the bregma to the subocciput. So this is called suboccipitobregmatic diameter. From subocciput to bregma, this is suboccipitobregmatic diameter. This is from mentos to vertex, mentovertical diameter. This is a suboccipitobregmatic diameter. This is the mentovertical diameter. Now this diameter, this is below the mentos, so submentovertical diameter. Okay, this is submentovertical diameter. This is mentovertical diameter, or submentovertical. Sorry, this is submentobregmatic diameter. This is mentovertical diameter. This is mentovertical diameter. This is submentobregmatic diameter, suboccipitobregmatic diameter. Now we have one diameter here left, that is called occipitofrontal diameter, from occiput to frontal bone. So in case of well flexed head, so remember one thing, this is an important concept I am telling you here. Suppose the head is like this, the head is suppose well flexed, and now I am flexing it. So this is the well flexed head. So well flexed head, the presenting part here is the vertex. This is the anterior fontanelle. This is the posterior fontanelle. So this is the vertex. The diameter, anterior posterior diameter, should be parallel to this. It is the catch. Okay, the anterior posterior diameter should be parallel to this. So this is the vertex, nearly parallel, but this is a rule, trick. I'm not saying this is the truth or written somewhere in the book. This is the way to remember it. Suppose this is the vertex, we have to do something that is somehow parallel to it. Okay, so this diameter is somehow parallel to it, you can see here, or I can modify it something like this. So this is the vertex presentation. We palpate the occiput, the denominator is occiput. Now this is the thing, this is the suboccipitobregmatic diameter, suboccipitobregmatic diameter. So this is the diameter, anterior posterior diameter of engagement in case of well flexed head or in vertex presentation. This is the diameter. Suppose now the same head is, now I am extending it. Suppose now we are going to extend it. Now we have extended head. So in extended or partial extended head, this is our presenting part, that is the brow. For brow presentation, the diameter, I set the rule that is somehow parallel to that. Remember, it's like this. What is this diameter? From mentos to vertex, this is mentovertical. So mentovertical diameter is the anterior posterior diameter of engagement in case of brow presentation, okay, or partially extended head. Now we are going to discuss about fully extended head. What is the fully extended head? The presenting part is face. So we are going to extend it fully. This is the fully extended head. Now here the presenting part is face. Now I have to take a diameter parallel to it. So what is the diameter? This is the diameter. Submento pragmatic. Submento pragmatic is the diameter somehow parallel to this. So this is the diameter in case of this. So this is the things are written here. So the fully flexed head, sub-occipital pragmatic 9.5 cm diameter, vertex occiput is the present the denominator. Vertex is the presenting part, diameter is the sub-occipital pragmatic diameter, head is well flexed. Now in case of partially extended head, brow is the presenting part, frontal bone is the denominator, mentovertical diameter I have told you, this is the mentovertical diameter, brow is the presenting part. Look, this is parallel, this looks parallel. Vertex is the one, the vertex is the presenting part, this diameter is the parallel. Okay, now if in case of fully extended head, that is face presentation, and the denominator is the mental prominence, and the diameter is somehow parallel to that face presentation. This is the diameter, submento pragmatic. So now in case of deflexed head means it is neither flexed somehow nor partially extended, in between them. In deflexed head, so this is the deflexed head, the diameter is occipital frontal diameter, parallel to that is the diameter of choice in deflexed head. Now I have to remember the length. I have told you the largest transverse diameter is biparietal diameter, that is constant 9.5 cm, remains always constant. Epidiameter is the one who changes according to the head position. So in partially extended, we have the brow presentation, frontal bone is the denominator, mentovertical diameter is 14 cm, it is the longest. Okay, mentovertical diameter is the longest in brow presentation. Mentovertical diameter is 14 cm, remember it. Mentovertical diameter is 14 cm. Submentopragmatic diameter, it is 9.5 cm. Submentopragmatic is 9.5, mentovertical is 14 cm. Now we have submentopragmatic. We have discussed about mentovertical, submentopragmatic. This is also 9.5. Submentopragmatic is 9.5. Suboccipital pragmatic also 9.5. Now we have the occipital frontal. This is occipital frontal. In case of deflexed head, this is 11.5. So the rule is this is 9.5, this is 9.5, this is 14, this is 11.5, biparietal diameter is 9.5. So these are the all diameters. Now we are going to discuss about the phases, the first stage of labor, that can be divided into two phases. One is latent phase, one is active phase. So we have guidelines, two different guidelines. One is WHO guidelines, another is SCOG guidelines. So according to WHO guidelines, the latent phase is when the cervical dilatation is 0 to 4 centimeter, and according to SCOG guidelines, the when we call latent phase if the cervical dilatation is 0 to 5 centimeter. So according to WHO, latent phase is cervical dilatation 0 to 4 centimeter. According to SCOG, the cervical dilatation is 0 to 5 centimeter in latent phase. And in active phase, what happens in active phase? active phase is more than, for WHO, active phase is cervical dilatation more than equal to 5 centimeter, because the latent phase is 0 to 4 centimeter, and according to SCOG it is more than equal to 6 centimeter. So another thing is prolonged. When this is the normal duration. What is the normal duration of the latent phase? In case of primigravida, the normal duration latent phase is 12 hours. In case of multigravida, the normal duration latent phase is 4 hours. For primigravida, normal duration of latent phase is 12 hours. For multigravida, normal duration of latent phase is 4 hours. When we will say it prolonged labor, for primigravida, if it is more than 20 hours instead of 12 hours, it is more than 20 hours, then we call it prolonged labor. For multigravida, instead of 4 hours, if it is more than 12 hours, then it is called prolonged labor. So now we are going to discuss about true versus false labor. So what is the difference between true and false labor? True labor is progressive dilatation and effacement. It is not progressive. Intensity and duration and frequency, all these are increases with time. It is not seen. Another thing is the management of labor or false labor, we can say sedation. If you give sedation the true labor, the patient can feel free from pain relief, but the contraction continues. Okay, but in case of false labor, the pain relief occurs plus the contraction subsides. So this is the best thing, I think. So if you give sedation, the pain relief continues in both, but the contraction never stops in case of true labor, but it stops, contraction subsides in case of false labor. So this is how you can differentiate between true and false labor. So what is so? So is the rupture of membrane. When the rupture of membrane occurs in second stage of labor, if the blood is mixed with cervical mucus, blood mixed cervical mucus is seen, that is called so. On sedation, pain relief, but labor continues, that is seen in true labor. Now we are going to discuss about Leopold maneuver. Leopold we have 6 maneuver. 3 we do while looking to the face of patient. Another 3 we will do while looking to the feet of the patient. The first Leopold maneuver is the fundal grip, and we know from the fundal grip about the presentation, cephalic presentation or breech presentation, and the lie, all these things. Leopard second grip, we'll know the which side the spine is present and which side the limbs are present. Okay, and the Leopard 3, that is called fast pelvic grip or poly grip. So that we'll do using one hand. The Leopard 1 and 2 we are doing using 2 hands, but Leopard 3 we are doing using one hand. So it's the largest fetal head diameter plus head. What is engagement? What is engagement? Engagement is when, and Leopard 3 we are knowing another thing, if the head is engaged or not. If we can palpate the full head like this, then it is not engaged. If it is engaged, we can palpate up to this, we cannot palpate the full head. So this is not engaged or not, we are knowing from the Leopard 3, that is called poly grip. We are using one hand, we can confirm it after the Leopard 3 doing Leopard 4. Okay, if the our hands we keep parallel to the inguinal ligament, if our hands are converging, that means the head is not engaged. If our hands are diverging, that means the head is engaged. So this is the thing. Now what is engagement? Engagement head at term in primigravida. That is non-engagement of head at term. Term 37 week. If the head is not engaged in case of primigravida at term, what can be the reasons? One is wrong dates, another is placenta previa, polyhydramnios, deflexed head. So non-engaged head at term in primigravida means wrong dates. Did you have wrong dates? Deflexed head, placenta previa, polyhydramnios, CPD. We will discuss about CPD later on. And the largest fetal head diameter passes the pelvis, that is called engagement. I have discussed about before. Now the station of the head. Station of the head means this is calculated according to ischial spine, so how much below the head has come. According to the level of ischial spine, we keep it 0, -1, -2, +1, +2. This is called station of the head. So this is important in Bishop scoring, and that we'll see later on. So position of the leading point of head in the maternal pelvis, that is called station of the head. Position of the leading point of head, So I draw the diagram. This is the leading point of head. So this is present in +1 station. So position of the leading point of head in maternal pelvis is called station of the head. So for vaginal examination, station 0 means head is the leading point of head is present at the level of ischial spine. Above means -1, -2. This -1, -2 is 1 centimeter above, and below means +1, +2, 1 centimeter below, and +3 means it is at the pelvic floor. The head is the leading part of head is at the pelvic floor. Now this is the thing we have discussed. Now let's go above. So what are the steps of normal labor? The steps of normal labor are engagement. We discuss about engagement, descent, flexion, internal rotation, 2/8 of internal rotation, crowning, extension, restitution. Restitution is not a cardinal movement. Crowning is also not a cardinal movement. Restitution means the shoulder remains at that position, but the head rotates 1/8. After that we see external rotation. Here both the head and shoulder both rotate by 1/8. So we can say external rotation total is 2/8. Internal rotation also 2/8. Anterior shoulder is now under pelvic symphysis. After the external rotation, delivery of the shoulder of baby by lateral flexion. So second stage of labor. So for priming avida, average duration is 1 hour. For multi avida, it is 30 minutes. No descent and rotation of head. If no descent and rotation of head, for priming avida, it is more than 3 hours. Multi avida more than 2 hours. And we can add +1 if we are giving epidural anesthesia, because it slows the process. So CPD means cephalopelvic dysproportion. It happens when the head of the baby and the pelvis of mother are not compatible with each other's side, so head docks in between. That is called cephalopelvic dysproportion. The management of CPD is always cesarean section. So if fetal death occurs in CPD, we can do institutional delivery or instrumental delivery. So what are the signs of CPD? Suppose a question shows CPD. What will they give as clues? One is caput succedaneum. Caput succedaneum is edema. When the head is engaged in a position for a long time, there will be edema on the top of head. That is called caput succedaneum. And another thing like this, we have cephalometoma, that is injury to the head while doing institutional delivery. Cephalometoma, we see the blood accumulation below the periosteum, but in case of caput succedaneum, it is above the periosteum. And in cephalometoma, it doesn't cross the suture line, so blood remains confined to a particular suture. If it is present like this side will be normal. This is cephalometoma, but caput succedaneum present wholly, because it contains normal fluid and it contains blood. So it starts after delivery, it starts later sometime, and it also takes longer time to resolve. So another thing, in case of CPD, one thing we see the caput succedaneum, that is edema. Another thing we see is molding. Molding means parietal bones overlapping each other. Normally molding is also seen when the baby is passing, the bones overlap with each other and the baby passes through. This happens in case of vertex presentation. Vertex presentation, the parietal bone can overlap each other or cross each other, and that will lead to narrowing of the diameter of head, and it will pass easily. But in case of face presentation, when the face is the presenting part, what happens here? Now the face bones will not overlap with each other. So in vertex, it was taking less time to deliver, but in case of face presentation, it will take more time to deliver, because these bones are not going to overlap over each other. So that's why the face presentation, it will take longer time to deliver, or the duration of the labor will be longer in case of face presentation. So that is the thing here. And molding can be divided into 3 grading: +1, +2, +3. 1+ means the bones are just touching each other. 2+ means bones overlapped but can be separated. 3+ means bones are overlapped and can be separated. So in CPD, the clue is caput succedaneum and molding. Molding is the parietal bone overlapping over each other, and the grade is 1 plus 2 plus 3 plus. 1 plus is bone at just touch each other, and 2 plus means they are overlapping each other but can't be easily separated. 3 means can't be separated, they are overlapping. Now we have partogram. Partogram we'll discuss in some other thing. Now another thing is WHO labor care guide. So this is the latest. So what is the difference between partogram or labor care guide? So in partogram we have alert line and absent line. Okay, no, sorry, action line and alert line. I have told it in absent. One is alert line, another is action line. So the here alert line present, this is action line is present. When the our graph is here before the alert line, this is normal. When the graph comes after the alert line, we have to get alert. When it comes near the action line or beyond the action line, then we have to take some intervention. So these are present in case of alert line and action line. This is present in partogram, but in WHO labor care guide there is no alert line or action line. So in second section, in first section obviously there will be information about the mother and all. In second section we have supporting care. This is included in case of labor care guide, which was not present in case of partogram. One is supportive care. Supportive care means companion, pain relief, all these things. And third section is about the total 7 sections I think here. So first section is about the maternal information. Second section is about the supportive care she receives. Third section is about the baby. Fourth section is about the vitals of the mother, the pulse, BP, all these things. Fifth section is cervical dilatation and descent. Cervical dilatation and descent. Cervical dilatation also present in case of partogram. So cervical dilatation and descent present in the fifth section. Fourth section contains vital parameters of the mother. Third section is about the baby. Second section is about the supportive care. First is about the mother information. And we have the sixth section that will write about the drugs. What drugs we are giving to the mother. That is the sixth section. And another thing here, 5 centimeter. So before WHO are considering labor from dilatation from 4 centimeter. Now it is considering from 5 centimeter. So this is now considered as 5 centimeter. Cervical dilatation starts from 5 centimeter, but in case of partogram it was starting from 4 centimeter. Another 7 section contains shared decision making. This was also absent in partogram. So what is shared decision making? What decisions doctors are taking while doing the delivery? So shared decision making. This is present in labor care guide, absent in partogram, present in the 7 section of labor care guide. Another thing is second stage of labor is included. So in WHO labor care guide, the second stage of labor is included. Another thing, for example, 3 consecutive contractions in 10 minutes. And what is that? What is the criteria for adequate contraction? So for the criteria for adequate contraction are we'll check in every 30 minutes, and in every 30 minutes we'll place our hand on the bump of the mother for 10 minutes. If we felt more than or equal to 3 contractions, more than or equal to 3 contractions, each lasting for more than 45 seconds. Okay, that is what is called adequate labor. If we are feeling more than 5 contractions in 10 minutes, that is called tachysystole, and that is not good for the baby because the uterus is contracting more and that will lead to decreased blood to the placenta and lead to fetal distress. Initially during the fetal distress there will be transient tachycardia followed by prolonged bradycardia, but when we are auscultating we will see the decrease in fetal heart rate or bradycardia, but the first stage is tachycardia in case of fetal distress. So what is Montevideo unit is an important concept. Suppose we are having 3 contractions in 10 minutes and each has pressure 80 mm of mercury. 3 contractions in 10 minutes and each has pressure of 80 mm of mercury. So for Montevideo unit is 3 into 80, number of contractions 10 minutes into number into pressure, 3 into 80, 240 Montevideo unit. Okay, I told you 5 contractions in 10 minutes, that is tachysystole, fetal distress, hypostimulation. Now we have to, if you are giving oxytocin, we have to stop it because it is contracting more and more, it can lead to fetal distress. Another thing is what will the management in case of tachysystole or the fetal distress? Put mother in left lateral position, give her oxygen mask, give her IV fluid. After that, if there is no change or the fetal distress persists, we can use tocolytics, that is terbutaline. And tocolysis is not fast term because it has also side effects. So after tocolysis, if now the fetal heart rate is normal and fetus is not distress is relieved, we can start again oxytocin, because now this time we have to lower this dose into half. So after tocolysis, if the fetal distress is relieved, now we can again start the labor with induced labor with the oxytocin, but this time we have to use the half of the dose that we have used before. So despite all fetal distress is present, then rule out cord prolapse, abruption, all these things. So after doing all these things, if there is persistent fetal distress, we have to rule out something, that is, one is cord prolapse, another thing is abruption. Cord prolapse is most commonly seen in case of transverse lie. Okay, cord prolapse and abruption placenta, that is blood stain. After that, we have the pelvis. Pelvis has three things: inlet, cavity, outlet. So inlet, this is the pelvic inlet. Pelvic inlet, we have diameters. So this is the first diameter, that is called the true conjugate. Second is called the obstetric conjugate. Third is called the diagonal conjugate. The true conjugate is about 11 centimeter. Obstetric conjugate is about 10.5 centimeter. True conjugate 11 centimeter. Obstetric conjugate 11.5 centimeter. And the diagonal conjugate is 12 centimeter. True conjugate from the upper border of pubic symphysis to sacral promontory. Obstetric conjugate from the sacral promontory to the posterior surface of pubic symphysis, can middle. And the diagonal conjugate is from the sacral promontory to the lower surface of pubic symphysis. So among this, the most important is obstetric conjugate, because we can define the contracted pelvic inlet based on the according to the obstetric conjugate. If it is normal 10.5 centimeter, if the obstetric conjugate is less than 8 centimeter, then we call it, less than 10 centimeter, then we call it contracted pelvis. If the obstetric conjugate is less than 10 centimeter, we call it contracted pelvis. Normal is 10.5. And the diagonal conjugate, we can measure it. Among all these true conjugate, obstetric conjugate, diagonal, we can measure the diagonal conjugate. How we can measure diagonal conjugate? Suppose this is the thing here, after pubic, this is our vagina. We put our two finger inside like this. This is, I put two finger inside and I put finger inside. This is the distance. We'll palpate our using our fingers. Ideally, we should not able to touch it. That means the length is adequate. So we can measure this distance, and this is the diagonal conjugate. Suppose diagonal conjugate is normally 12 centimeter. So obstetric conjugate is what? 12 minus 1.5, that is 10 centimeter. Suppose in a patient we get the diagonal conjugate at 13 centimeter. Now what will be the obstetric conjugate? 13 minus 1.5, that is what? 11.5 centimeter. Suppose we get the diagonal conjugate as 9 centimeter. So what will be the obstetric conjugate? 9 minus 1.5, what is that? That is 7.5 centimeter. It is obviously less than 10 centimeter. That means it is a contracted pelvis. So if the pelvis is contracted or not, we can know using the diagonal conjugate, which we can measure clinically. Now we are going to discuss about the cavity of the pelvis. So cavity of the pelvis, we have some shortest diameter, largest diameter. Shortest diameter is the interischial diameter. Okay, shortest diameter is the interischial diameter between the two ischial tuberosities, that we can also clinically measure using fingers. If we can touch it easily, that means it is adequate. If it is not able to touch two simultaneously, that means it is adequate. Using two fingers, I have the image, I will show you later, but if I am not able to touch them, then it is adequate. So interischial diameter normally is 10.5 centimeter. If it is less than 8 centimeter interischial diameter, then it is called contracted pelvis, and we see the deep transverse arrest in this case, deep transverse arrest. And remember one thing, that here the obstetric conjugate is also 10.5 centimeter, interischial diameter is also 10.5 centimeter. But in case of obstetric conjugate, when we will say contracted pelvis, the obstetric conjugate less than 10. But in case of interischial diameter, we will say contracted pelvis if the interischial diameter is less than 8 centimeter. Okay. Now about the outlet. Outlet means the largest. So the largest cavity diameter, that is the plane of greatest pelvic dimension. Okay, these are the planes. So this is the pubic symphysis. This is the sacral promontory. Now this is plane. From the top of the pelvis symphysis to sacral promontory, the true conjugate. This is the true conjugate, or this is also called the anatomical conjugate, the pelvic inlet. Now between the intervertebral disc of S2 S3 to the pubic symphysis, between the disc of S2 S3 to S2 S3 junction to the pubic symphysis, this is called plane of greatest pelvic dimension. So this is the largest diameter of the cavity, that is called plane of greatest pelvic dimension. The space between posterior surface of pelvic symphysis to the S2 S3 junction. So the space between posterior surface of pelvic symphysis to the S2 S3 junction, this is called the plane of greatest pelvic dimension. So after that, this thing we have pelvic symphysis. From the lower border of pelvic symphysis crossing the ischial spine, we go to the junction of S4 and S5. That diameter what we will get if we start from the lower border of pelvic symphysis, cross the ischial spine on both sides and go up to the S4 S5 junction. That plane we get, that is called plane of least pelvic dimension. Another thing, we have the obstetric outlet. Obstetric outlet means it starts from the lower border of pubic symphysis, goes along the ischial tuberosity and goes toward the coccyx. Let's remember one thing, this obstetric conjugate, and this thing is called obstetric outlet. Obstetric outlet is between the plane of least pelvic dimension and anatomical outlet from the floor of obstetric conjugate. Okay, so this is the mid pelvis. Mid pelvis is between plane of greatest pelvic dimension and plane of least pelvic dimension. This part, this is called mid pelvis, between the plane of least pelvic dimension and anatomical outlet. This part, this is called obstetric outlet. And this is called mid pelvis. This is mid pelvis, this is obstetric outlet. And what is the common plane between mid pelvis and obstetric outlet? It is the plane of least pelvic dimension. So another type of abnormal pelvis we have, that is called Robert pelvis, in which two valleys of sacrum are absent. In another thing we have called necklace pelvis. In necklace pelvis, one ala is absent. These are both abnormal pelvis. We can't do normal delivery here. We have to do cesarean section in case of abnormal necklace pelvis means one ala absent. Robert pelvis means two ala absent. Another thing, type of pelvis we have called platypelloid pelvis. In platypelloid pelvis, the face and brow presentation are most common presentation. I told you here what is the common presentation in case of face presentation or brow presentation. That is in case of platypelloid pelvis. So platypelloid pelvis, face and brow presentation are very common. This is the android pelvis. Android pelvis means it is heart-shaped pelvis. In android pelvis, we have occipito posterior position is more common. This is right occipito posterior. So an occipito posterior position is common in case of android pelvis because this is the space it have. So occipito posterior presentation is common in case of android pelvis. This is called anthropoid pelvis. Anthropoid pelvis we have direct occipito posterior. This is right occipito posterior, left occipito posterior, but this is direct OP. So this is in case of anthropoid pelvis. Android pelvis is most common cause of occipito posterior presentation. In contracted pelvis, interstitial diameter less than 8 cm. Direct OP, occipito posterior presentation, which is in case of anthropoid pelvis. Now if it is in ROP, how it will get to normal position? You have to rotate like this. So from ROP, right occipito posterior, it have to rotate 1/8 more. When it rotates 1/8 more, it called to right occipito transverse. From right occipito transverse, it will go from ROP to it will go to right occipito transverse to right occipito anterior, then completely occipito anterior. This is rotated like this. So this is rotating 1/8, 1/8, 1/8. Total 3/8 rotation. It will go to occipito anterior. There will be, it will arrest in between. There will be anomalies. We will discuss that later. In normal case, our presentation is the cervix. This is the presentation. Left occipito transverse. You have to rotate 1/8. Left occipito anterior. Rotate more 1/8. This is occipito anterior. This is total 2/8 rotation. 2/8 rotation normal skin. And in case of right occipito posterior presentation, and the occipito posterior presentation, the most common right occipito posterior presentation, it is in 3/8 presentation. In case of anthropoid pelvis, it doesn't rotate like this. It rotates reversely and occupy the direct occipito posterior presentation in case of arthropod pelvis. Now I think I have discussed all these things. So this is all about this phase of normal labor. I will make another video about this only. Thank you.